Good day. In this video, I will be showing to you how to do a tracheostomy procedure. Here are the materials you need: DIY suture, blade holder, needle holder, mosquito forceps, Matthew Sen and Army Navy retractors, straight and curved Mayo scissors, electrocautery, the neck model, suction, tracheostomy tube, syringe and catheters, gauze, and marker. Tracheostomy is the creation of a communication between the trachea and the overlying skin. General indications for the placement of tracheostomy include acute respiratory failure with the expected need for prolonged mechanical ventilation, failure to wean from mechanical ventilation, upper airway obstruction, difficult airway, and copious secretions. Tracheostomy is also the definitive treatment of obstructive sleep apnea. In positioning, place the patient in a supine position with the neck extended by a pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Sterilize the skin of the anterior neck and the chest. Afterwards, drape the neck. Before the surgery starts, palpating the prominent landmarks and marking them is a very important step in incision planning. This includes the thyroid prominence, cricoid cartilage, and the sternal notch. The incision can be placed 2 cm or 2 finger breadths superior to the sternal notch. Again, it's very important to emphasize sterilization of the area to be incised to avoid infectious complications afterwards. Prior to surgery, the skin should be injected with anesthesia, which is usually 1% lidocaine with 1:100,000 epinephrine solution. To start the procedure, a horizontal incision is usually done since it is cosmetically preferable to a vertical midline incision. Extend the incision through the skin and subcutaneous tissue, passing the platysma, which is generally absent in the midline. Continue dividing the infrahyoid fascia until strap muscles are identified. Care should be in the mind of the surgeon to not transect the anterior jugular veins, which are just superficial to strap muscles. Divide the intermuscular plane by spreading with a pair of scissors. Repeat the maneuver to separate the muscles and retract the muscles afterwards laterally. Intermittent palpation of the airway is important for the surgeon not to go away from the midline. Once the pretracheal fascia is seen, remove this layer and you can either remove some tissues of the thyroid gland or retract them superiorly using retractors. Once the trachea is already visualized and exposed, create an inferiorly based flap from the anterior wall of the 3rd and 4th tracheal rings. The inferior flap is sutured to the skin of the inferior wound margin, and this has the important advantage that displacement of the tube into the pretracheal space cannot occur and replacement is easy. In the insertion of tracheostomy tube, select the largest cuffed tracheostomy tube that comfortably fits the tracheal lumen. You then insert the tracheostomy tube, remove the obturator, and place the inner cannula afterwards. Secure the tracheostomy tube by suturing it not too tightly onto the skin of the patient to avoid surgical emphysema. The tube is then externally secured by threading tape through the holes in the flanges of the tracheostomy tube and passing them around the neck. Tracheostomy complications can actually be considered in 3 time frames: immediate, early, and late. This includes hemorrhage, tube displacement, infections, pneumonia, fistulas, and even death. I hope you have learned something. Thank you for watching.